Introduction. Diabetic nephropathy is a chronic kidney disease that develops as a complication of diabetes mellitus. It is characterized by the progressive damage to the kidneys, leading to impaired renal function. Understanding the pathophysiology of diabetic nephropathy is crucial for the development of effective treatment strategies to slow down or prevent its progression. In this detailed script, we will explore various aspects of diabetic nephropathy, including the pathophysiological mechanisms involved and the role of different factors in the development and progression of this condition. Diabetic nephropathy begins with the long-standing effects of prolonged hyperglycemia on the kidneys. High blood glucose levels cause metabolic disturbances that result in increased oxidative stress and the activation of various molecular pathways. These pathways include the polyol pathway, the hexosamine pathway, and the advanced glycation end product, AGE, pathway. The interaction of these pathways contributes to renal damage, characterized by glomerulosclerosis, tubulointerstitial fibrosis, and arteriolar hyalinosis. Tubulointerstitial fibrosis is a key feature of diabetic nephropathy and is associated with the loss of renal function. It involves the deposition of extracellular matrix proteins, such as collagen, in the tubular and interstitial compartments of the kidneys. This fibrotic process is mediated by various profibrotic factors, including transforming growth factor beta, TGF-beta, connective tissue growth factor, CTGF, and the renin-angiotensin system. Understanding the molecular mechanisms underlying tubulointerstitial fibrosis can provide insights into potential targets for therapeutic interventions. Advanced glycation end products, AGEs, are formed as a result of non-enzymatic reactions between reducing sugars and proteins. In diabetic nephropathy, elevated levels of AGEs contribute to renal damage by promoting inflammation, oxidative stress, and the activation of profibrotic pathways. AGEs interact with their receptors, RAGE, on various cells, including mesangial cells, podocytes, and tubular cells, leading to the production of pro-inflammatory cytokines, growth factors, and extracellular matrix proteins. One of the histopathological hallmarks of diabetic nephropathy is the thickening of the glomerular basement membrane, GBM. The GBM is composed of collagen 4 and other extracellular matrix proteins. In diabetic nephropathy, the increased deposition of extracellular matrix proteins in the GBM leads to its thickening. This thickening impairs the glomerular filtration barrier and contributes to proteinuria, a common clinical manifestation of diabetic nephropathy. The intrarenal renin-angiotensin system, RAS, plays a critical role in the regulation of renal hemodynamics and sodium balance. In diabetic nephropathy, the RAS is dysregulated, leading to increased production of angiotensin II, a potent vasoconstrictor. Angiotensin II promotes renal inflammation, fibrosis, and oxidative stress, contributing to the development and progression of diabetic nephropathy. Targeting components of the intrarenal RAS has been an effective strategy for the treatment of diabetic nephropathy. Emerging evidence suggests that the presence of renal autoantibodies may play a role in the pathogenesis of diabetic nephropathy. These autoantibodies target specific renal antigens, leading to inflammation and immune-mediated damage to the kidneys. Understanding the role of renal autoantibodies in diabetic nephropathy may open avenues for the development of novel diagnostic markers and therapeutic interventions. Renal hypertrophy, characterized by an increase in the size of kidney cells and organ weight, is a common finding in diabetic nephropathy. Hyperglycemia, insulin-like growth factor 1, IGF-1, and other growth factors contribute to renal hypertrophy and diabetes. Targeting pathways involved in renal hypertrophy may have therapeutic potential in preventing or delaying the progression of diabetic nephropathy. In diabetic nephropathy, renal hypoxia and ischemia play a significant role in the pathogenesis of kidney damage. Chronic hyperglycemia, increased oxygen consumption, altered oxygen delivery, and impaired renal blood flow all contribute to the development of renal hypoxia and ischemia. These conditions trigger a cascade of events, including the activation of hypoxia-inducible factors and the production of pro-inflammatory and profibrotic mediators, leading to renal injury. Inflammation is a critical component of diabetic kidney disease. Various pro-inflammatory cytokines and chemokines are upregulated in the kidneys of individuals with diabetic nephropathy. These inflammatory mediators contribute to renal damage by promoting the recruitment of immune cells, stimulating fibrosis, and impairing renal function. Targeting inflammatory pathways may offer new therapeutic strategies for diabetic nephropathy. Epigenetic modifications, including DNA methylation, histone modifications, and non-coding RNAs, have emerged as important regulators of gene expression in diabetic nephropathy. These epigenetic changes can be influenced by environmental factors, including hyperglycemia and oxidative stress. Understanding the epigenetic mechanisms involved in diabetic nephropathy may provide insights into potential therapeutic interventions for this condition. Altered renal hemodynamics, characterized by increased glomerular filtration rate and increased renal blood flow, are observed in the early stages of diabetic nephropathy. These hemodynamic changes contribute to the hyperfiltration of the kidneys and the subsequent development of glomerular injury. The precise mechanisms underlying these hemodynamic alterations are complex and involve the dysregulation of various vasoactive factors and tubuloglomerular feedback. Glomerular hyperfiltration, defined as an increase in the glomerular filtration rate, GFR, above normal levels, is a characteristic feature of the early stages of diabetic nephropathy. It is considered a compensatory response to the increased metabolic demands in diabetes. However, persistent glomerular hyperfiltration can lead to glomerulosclerosis and the progression of renal damage. Understanding the mechanisms underlying glomerular hyperfiltration can help in the development of therapeutic strategies to mitigate its detrimental effects. In conclusion, diabetic nephropathy is a complex disease involving multiple pathophysiological processes. From the initial effects of hyperglycemia to the development of tubulointerstitial fibrosis, inflammation, and glomerular injury, numerous factors contribute to the progression of renal damage in this condition. Understanding the intricate mechanisms at play and identifying potential molecular targets holds promise for the development of effective treatments to alleviate the burden of diabetic nephropathy. Continued research in this field is essential to improve patient outcomes and ultimately prevent the development of end-stage renal disease.